In this lecture, I will discuss formation, branches, and lesions of the brachial plexus. Here we will talk about the brachial plexus because all major nerves that innervate the upper limb originate from the brachial plexus, mostly from its cords. The brachial plexus, this is the brachial plexus, is a somatic plexus, originates in the neck from the union of the primary ventral rami of the lower four cervical nerves and the first thoracic nerve. Lower four cervical nerves include cervical nerves from C5 to C8. The brachial plexus passes downward and laterally, crossing the first rib, then passes to the axilla. Along the course of the brachial plexus, it has four parts: roots, trunks, divisions, and cords. The roots are the primary ventral rami of the lower four cervical nerves and the first thoracic. C5 and 6 unite to form the upper trunk. C7 continue as the middle trunk. C8 and T1 unite to form the lower trunk. So we have upper, middle, and lower trunks. Now each trunk divides into anterior and posterior divisions. The upper trunk gives the anterior and posterior division. The middle trunk gives this is the anterior and this is the posterior division. The lower trunk gives this is the anterior division and the posterior division. Now the last part, which is the cords. The anterior division of the upper and the middle trunks unite to form the lateral cord. This is the lateral cord. The anterior division of the lower trunk continues as the medial cord. This is the medial cord. The posterior divisions of the three trunks, this is the posterior divisions of the three trunks, unite to form the posterior cord. The cords are named lateral, medial, and posterior according to their relation to the second part of the axillary artery. Branches of the brachial plexus constitute branches from the roots, branches from the upper trunk, and branches from the three cords. Branches of the roots include three branches: root to the phrenic nerve, dorsal scapular nerve, and long thoracic nerve or nerve to serratus anterior. Two branches arise from the upper trunk: nerve to subclavius and suprascapular nerves. The middle and the lower trunks have no branches. Also, the divisions have no branches. The branches of the cords include three branches arise from the lateral cord: the lateral pectoral nerve, lateral root of the median nerve, and musculocutaneous nerve. 5 branches arise from the medial cord: medial pectoral nerve, medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, medial root of median nerve, and the ulnar nerve. 5 branches arise from the posterior cord. It include the upper and the lower subscapular nerves, with the thoracodorsal nerve in between. Thoracodorsal nerve is also called nerve to latissimus dorsi muscle. The fourth branch is the axillary nerve, and the continuation of the posterior cord is called the radial nerve. A traumatic brachial plexus injury involves sudden damage of any of the nerves that form the brachial plexus, and this may cause weakness, loss of feeling, loss of movement in the shoulder, arm, or the hand. Two main types of the brachial plexus root injury: the upper root injury and lower root injury. The upper root injury involves C5 and C6 roots. The lower root injury includes injury of C8 and T1 roots. The upper root injury caused by increased angle between the head and shoulder, as falling down from high distance, leading to increase the angle between the head and shoulder, and thus traction on C5 and 6 roots. Here also, during difficult delivery, there is traction on the head of the baby, leading to increase the angle between the head and shoulder, and also traction on C5 and 6 roots. Traction on the C5 and 6 nerves leads to herpes palsy or herpes paralysis. This paralysis has motor and sensory effects. The motor effects involve the shoulder, elbow, and the forearm. As we see here, the arm hangs by the side due to adducted and medially rotated shoulder. The elbow is straight, extended elbow. The forearm is medially rotated or pronated. This motor effect is called waiter's tip deformity. Sensory effects include numbness or even loss of sensation on the lateral side of the upper limb. Now the lower root injury, injury of C5 and T1 roots, is caused by excessive abduction of the arm. Excessive abduction of the arm leading to violent compression on C8 and T1. The most common causes are excessive traction on the upper limb during difficult delivery and cervical rip. Injury of the lower root of the brachial plexus involves mainly T1, but C8 may be also involved. It leads to lumbex palsy. As we see here, the motor effects leads to what is called claw hand deformity. It includes hyperextension of the metacarpophalangeal joint. This joint is straight here, straight metacarpophalangeal joints with flexion of the interphalangeal joints, flexion of the fingers. Also, the patients are unable to abduct or adduct their fingers. It is accompanied also by sensory effects, that includes loss of sensation on the medial side of the arm. If C8 is involved, loss of sensation on the medial side of the forearm and medial two fingers also occurs. Regarding the distribution of the branches of the brachial plexus to the upper limb. Briefly, we have anterior division nerves and posterior division nerves. The anterior division nerves or branches means the branches of the lateral and medial cords of the brachial plexus. The posterior division branches means the branches of the posterior cord of the brachial plexus. The anterior and the posterior divisions of the brachial plexus coincide with the limb compartments. I mean, the anterior division nerves that include the musculocutaneous nerve, median nerve, and ulnar nerves with other nerves discussed before are distributed to the regions of the upper limb that represent the embryonic ventral surface. I mean the flexor muscles of the upper limb. However, the posterior division nerves that include the axillary nerve and the radial nerve supply the regions of the upper limb that represent the embryonic dorsal surface or the extensor muscles. Now I will talk about the distribution and injuries of the median nerve. As we see here, the median nerve has no branches in the arm. In the forearm, it supplies the muscles of the front of the forearm except 1.5 muscles. In the hand, it supplies the thinner muscles and the first and second lumbricals muscles. It's a cutaneous distribution in the hand. It supplies the lateral 2/3 of the palm of the hand, also the palmar aspect and the nail beds of the lateral 3.5 fingers. The median nerve, by this distribution, control some of the hand muscles and allows feeling sensations. The median nerve injury could occur along 3 levels. First level is above the elbow by supracondylar fracture of the humerus. The second level is above the wrist. It is caused mainly by a stab wound. The third level is along the passage of the median nerve through the carpal tunnel, which is called the carpal tunnel syndrome. We can see here the carpal tunnel, which is a narrow passageway surrounded by bones, the carpal bones, and the ligament, the transverse carpal ligament. And along this passage, tendons with their synovial sheaths and the median nerve travel to the wrist. The carpal tunnel syndrome is caused by pressure of the median nerve along its travel through this narrow passageway. If this occurs, the symptoms include numbness, tingling, and weakness in the hand and arm. It may be caused by hereditary background or by repetitive hand use or during activities that involve extreme flexion or extension of the hand and wrist for a prolonged period of time. This increases the pressure on the nerve. Also, it could be aggravated by the hormonal changes during pregnancy or by some health conditions like diabetes, rheumatoid arthritis, and thyroid gland imbalance. Carpal tunnel syndrome include motor and sensory effects. Motor effects include abs hand deformity and weak thenar muscles. As we see here, this is the thenar muscles that are wasted and weak. Also, the thumb is severely affected. It is extended and adducted, being in the same plane as the palm and the other fingers. All are in the same plane. The thumb has very limited or even no ability to adduct or oppose toward other fingers. The sensory effects include paresthesia or even anesthesia to the palmar aspects and the nail beds of the lateral 3.5 fingers. Now the second nerve that arises from the anterior divisions of the brachial plexus is the ulnar nerve. What is the distribution of the ulnar nerve in the upper limb? The ulnar nerve has no branches in the arm like the median nerve. In the forearm, it supplies only 1.5 muscles of the front of the forearm, but its main distribution is to the intrinsic muscles of the hand. It supplies all the intrinsic muscles of the hand except those supplied by the median nerve, which are the thenar muscles and the first and second lumbricals. The sensory distribution is to the palmar and dorsal aspects of the the medial third of the hand, plus the palmar and dorsal aspects of the medial 1.5 fingers. Injury of the ulnar nerve occurs at two levels, either above the elbow due to fracture of the medial epicondyle along its way on the posterior aspect of the medial epicondyle, or above the wrist through stab wound or through compression of ulnar nerve on its way through the Guyon's canal. Injury of the ulnar nerve lead to a number of motor and sensory effects. These effects differ according to the level of injury. If the injury occurs above the wrist, the resulted motor effects include partial claw-hand deformity, loss of abduction and adduction of the fingers, loss of adduction of the thumb with flattening of the hypothenar eminence. Claw hand or ulnar claw is a deformity or abnormal attitude of the hand, as we see in this figure. It occurs due to paralysis of a group of intrinsic muscles of the hand called lumbricals. The claw hand presents with hyperextension of the metacarpophalangeal joints, with flexion of the proximal and distal interphalangeal joints, especially of the fourth and fifth digits. So it is called partial, not complete claw hand. If the lesion occur above the elbow, I mean more severe lesion, the deformity is less apparent. So the more severe lesion but less apparent deformity. The radial nerve is a branch of the posterior division of the brachial plexus. It supplies the extensor of the elbow, which is the triceps muscle. It gives the branches to the lateral and medial heads of the triceps muscle. Also, it supplies the 12 muscles of the posterior compartment of the forearm. That includes the extensors of the wrist and fingers. The sensory function of the radial nerve, it provides cutaneous innervation to the anterolateral part of the arm and the distal posterior part of the arm, plus the posterior aspects of the forearm and the posterior aspects of the lateral 3.5 fingers. Now, what are the causes and the effects of radial nerve injury? Radial nerve could be injured in the axilla or in the spiral groove of the humerus. In the axilla, the cause of injury may be pressure from a crutch or hanging the forearm on the back of a chair. In the spiral groove, radial nerve could be injured due to a fracture of the shaft of the humerus. The symptoms of injury of the radial nerve are tingling and numbness on the back of the arm, forearm and hand, plus motor effects leading to wrist drop and finger drop. I mean inability to flex the wrist or the fingers. The same symptoms occur if the injury includes the radial nerve in the spiral groove. But injury of the posterior interosseous branch of the radial nerve could occur on the lateral side of the radius due to fracture of the head, neck or upper shaft of the radius, or due to downward dislocation of the radius head. The symptoms include only inability to extend the fingers, what is called finger drop, but the wrist flexion is preserved. Thank you.